Optimizing biomarkers and choosing therapy in multiple cancer types is huge right now, and it's such a challenge. And I think part of the issue is there's so many different tests out there, a fair amount of confusion. The clinicians think one thing, the pathologists may not be completely up to date, or if they are, they have a different lens they look at this with. So it is a challenge, no doubt about it. At our center, what we've done is we've created a committee that is looking at this as data comes out. It's a committee made up of pathology and clinicians, and whoever else needs to be involved, but basically those two main groups. We literally created this group more than a year ago now because we knew this was becoming an issue. And the clinicians wanted reflexive testing on one side. The pathologists said, no, I don't want to do reflexive testing. You got to tell me. And we come to a consensus together as to what should be reflexively tested for our tumor types. So, for example, in melanoma, we know that every patient now, because there's adjuvant data out there now, that every patient with a new diagnosis of melanoma, we get a reflexive BRAF testing, for example. We don't do anti-PD-L1 in melanoma reflexively because it's not very helpful, but I might do that for patients when I'm trying to select combination immunotherapy versus monotherapy. In lung cancer, for example, it's very well established what's needed to be done. And I think in the lung cancer world, the challenge has been that a lot of people do these markers, if you want to call them biomarkers, or whatever you want to call them, sequentially and not all together. And I think that delays treatment. Every test takes a week or sometimes longer to come back. And on paper, it might be 4 days, but in practice, it takes 2 weeks, 3 weeks to get this. So we are making concerted efforts in lung cancer for our lung cancer group to get a panel of biomarkers upfront. And that then can direct therapy now and in the future. It's a challenge, though. I think my recommendation is that every center look at this in a consensus group, because reflexive testing is expensive and pathologists don't like that. When you bring up the word reflexive, they don't like it. They want you to tell them why you want it, when you want it, and give a reason. And it makes total sense that they should ask for that. But I think if we sit down with them together, they'll see the value of this and how it can actually enhance patient care and prevent delays in treatment. That's the biggest thing. The other part of it is who owns this tissue. By that I mean who's seeing the patient first. Sometimes it's a thoracic surgeon for a lung cancer patient. It's a dermatologist or a surgeon for a melanoma patient. And they need to be in the loop too. So getting this set up as a process in your network or your system or your hospital system is very useful.